The task I was given today was to really focus on some of the classic effects of radiation therapy. And what I want to do is try and weave this into the theme of neuromodulation that we're focusing on today. This is what I call my confluence of interests rather than conflicts of interests, because I have learned from Dr. Adler that I love the phrase, if you have no conflict, I have no interest, so then I talk about confluences. So my objectives are to do some basic radiobiological review just to get everybody up to speed about what the 5 R's of radiobiology are. Put this in the context of hypofractionation, large dose per fraction. What is it about large dose per fraction that we need to think about as a friend or a foe, and compare this with standard radiotherapy, and then finally introduce this as a basis for neuromodulation and radiomodulation, which is really the theme of the topic today. So why is this important? We know that radiobiological mechanisms underpinning the effects of high dose per fraction radiation are very poorly understood. Historically, standard fractionated radiotherapy is explained with the 5 R's of radiobiology, which are reoxygenation, repopulation, redistribution, repair, and radioresistance. And if you read a classic textbook of radiobiology, it would say this explains everything you need to know about the mechanisms of radiotherapy. And we know that that statement is patently untrue. We have a lot of preclinical data that show that there's significant interaction beyond DNA, because the classic mechanisms rely on DNA damage. We know the microenvironment, the microvasculature, the immune system, all of these interplay with the effects of radiation therapy, and the 5 R's do not account for any of these elements of interplay. So non-DNA directed damage, change from high dose radiation, is unaccounted for, and in fact probably forms the basis for radiomodulation. So probably radiomodulation should be the 6th R in terms of the 5 R's of radiobiology. This could be the 6th R. But let's start with the basic concepts that underpin fractionation. So this is an extremely old slide that shows the effect on cells in culture. The blue curve is a single fraction of radiation. That's the most efficient way to kill cells. You use the lowest dose to kill the maximum number of cells, and that's the blue curve. It's a log linear plot, as you can see. However, when you start fractionating, so you can see 3 fractions in black, 5 fractions in green, and then red fraction is what we call the limiting dose slope, so you can put as many fractions as you want. You won't go lower than that. You start using more and more radiation to achieve the same level of cell kill. And the reason for this is between the fractions of radiation, there is repair and repopulation that is occurring within any cellular system. So fractionation is patently inefficient. You're now spending more of your resource, more of your radiation to achieve the same level of cell kill. So in this context, one would argue that single fraction radiation is the most efficient way to achieve cell kill. That, in fact, forms the basis for stereotactic radiosurgery and stereotactic body radiotherapy. But what do we mean when we use these phrases SRS and SPRT? So conventional fractionation, again, to put it in context, is typically the delivery of 1.8 to 2 gray of radiation per fraction, typically at a rate of about 4 to 5 fractions per week, typically over a course that extends more than 4 weeks. Hypofractionation doses typically exceed 2 gray per fraction. But there are different flavors of hypofractionation. You have moderate hypofractionation that is just 2.5 to 3 gray per fraction. It's commonly used in the clinic with extensive experience, very, very safe. We have extreme hypofractionation, which is where stereotactic radiosurgery comes in, where doses are typically in the range of 15 gray or more per fraction, can of course exceed much more than 15 gray, and are typically delivered in 1 to 3 fractions. And of course, we now have extensive experience, not just in the brain, but also extracranially with this schedule of fractionation. And then we have intermediate fractionation schedules that are infrequently used in the clinic. Now, what is intriguing is that the extreme hypofractionation doses of, say, for example, 15 gray, 18 gray, 20 gray, we think that these are actually very, very high doses. But in fact, that's not true. If you look at pure radiobiological modeling experiments, these experiments suggest that if you want to achieve cell kill in a tumor of approximately 3 centimeters in size, you would need about 80 to 90 gray in a single fraction. We never do that. We never give 80 to 90 gray in a single fraction, and yet we get good clinical results. So clearly the radiobiological models of cell kill do not explain everything, and there are probably other mechanisms at play. We know, for example, in the liver, tumors of up to 5 to 7 centimeters can be destroyed with 18 gray times 3. 54 gray can result in greater than 90% control at 2 years. What are the other underlying mechanisms? There are several of these. Endothelial damage is a proposed alternative mechanism to explain some of these surprising findings. And we in fact know that large doses per fraction, 10 gray or more, can produce significant microvascular dilatation, constriction, occlusion, rupture, perfusion changes, thrombotic events, and downstream necrosis. We also know that there's significant antigenic and chemokine release with doses in this level, and these would in fact induce a cascade effect. The recovery effect is an important R of radiobiology to understand. Recovery is irrelevant if you're giving all the doses in the single fraction, because you're giving all of your radiation dose and you're done and dusted. But if you're fractionating the radiation dose, in between the fractions of radiation, tissue will repair radiation damage. And in a simplistic manner, tumors are less capable of repairing radiation damage compared to normal tissue. And as the fractional dose goes up, the repair capacity is impeded even greater. Therefore, fewer fractions with less total dose is necessary to achieve the same effect because the repair capacity is overwhelmed. This could be another mechanism that explains why we can get away with lower than modeled doses to achieve the appropriate cell kill. Of course, this varies by tissue type and is frequently explained using what is known as the linear quadratic model. In the linear quadratic model, the hypothesis is that the tissues with an alpha beta value that are lower are substantially more susceptible to the impact of large fraction radiation. So let me explain this a little more. The alpha beta phenomenon was first defined to predict biological responses. The biologic effect of radiation we know are dependent on total dose, on dose per fraction, on the dose rate, and the overall treatment time. The LQ model takes all of these elements and integrates them in a single model where alpha and beta represent intrinsic cellular radiosensitivity. The alpha beta ratio is a measure of this sensitivity in a manner where cells with lower alpha beta ratios typically are slowly proliferating. So normal brain, for example, would have a low alpha beta ratio. More sensitive tissues, such as mucosal tissues, tumors, etc., have high alpha beta ratios and are therefore more susceptible to acute radiation injury. Alpha represents the irreparable double-strand DNA damage. In other words, you get the radiation dose, you get a double-strand DNA damage, that cell's never going to repair it again. Beta represents single-strand damage, which means it's potentially repairable. So this is sublethal damage or repairable damage. And therefore, it's going to be tissue-specific. A tissue with better repair capacity is going to repair the beta effect much more easily than a tissue that's less able to repair this. Now, if you look at this model, you quickly come to the realization that radiation effects on anything other than DNA damage are not modeled by the linear quadratic equation and the alpha beta model. Damage to the membrane, mitochondria, endothelial, vascular effects, antigenic effects, none of these are modeled in the alpha beta model. So here's an example of what the alpha beta ratio can be used to in fact represent. The initial slope denotes DNA damage labeled as alpha. That's the double strand damage that won't be repaired by the cells. The shoulder denotes the beta or the repairable damage, and the dose at which the damage from alpha and beta is equivalent or comparable is the point where you measure the alpha beta ratio, which I think in this particular slide is at about 9 gray. Tissues with lower alpha beta, as I pointed out, are more susceptible to high dose per fraction radiation. So we can now look at 3 different types of tissues here, tissues in red, green, and blue. The tissues in blue have a different alpha beta ratio compared to the tissues in red, and the green represents the central tissue values. So let's look at the red with an alpha beta of 1.5. This could be spinal cord, this could be normal brain, and contrast that with the blue, which is an alpha beta ratio of 10 gray, which would be a typical epithelial neoplasm, a proliferating neoplasm, or acute mucosa like the mucosa of the esophagus. And we can see on this axis, on the x-axis, it's dose per fraction. On the y-axis, it's the equivalent total dose of radiation as measured in comparison to 2 gray fractions. Clearly, tissues in blue, which is an alpha beta of 10 gray, require lower dose to get an acute effect than tissues with a higher alpha beta ratio. And hence, when we treat, for example, a head and neck cancer, We see acute damage to the mucosa because it's as sensitive as the tumor, but we don't see it to, for example, the thyroid gland, which has a significantly different alpha-beta ratio, and the same would apply in the brain. Now, the alpha-beta ratios result in what are called dose-response curves. Some curves are very, very steep. This is the dose-response curve for damage to the rib from stereotactic fractionated radiotherapy for lung lesions. So we give very high doses to ablate lung lesions. The rib is sitting right next to it. The damage to the rib is a function of this sigmoidal dose-response slope, and it is in fact very, very steep. In contrast, if we look at dose-response curves for nerves, cranial nerves, these curves are shallow. So these are old data that come from John Flickinger, from work done on treating vestibular schwannoma patients, and we can see that the 5th, 7th, and 8th nerve dose-response curves are much more shallow compared to the dose-response curves for rib fractures. So each tissue is going to have a unique responsiveness as the dose per fraction changes. Why is this important? When we start radiomodulating, when we start using large doses in the brain, each substructure will likely have a different dose-response curve, and we'll need to know this to make sure that we have the right balance of toxicity versus efficacy. To explain this better, Park and colleagues developed what is known as the universal cell survival curve, which is an attempt to get past the alpha-beta limitations. This universal cell survival curve, although published, is not widely accepted and is believed to be flawed. I just show this as an example of trying to do something other than an alpha-beta ratio curve, but we really don't have a well-modeled alternative to the alpha-beta ratio at this point. The reason for that is we're not able to model these other effects, these other changes. The effects in terms of vascular collapse, radiomodulation, immune stimulation, these are things we simply cannot model on the current alpha-beta model. Let's take a look at the vascular damage component as an example. This is a paper that was actually done on a very elegant experiment where a Walker 256 carcinoma was implanted in Sprague-Dawley rats, and different doses of radiation were delivered. The endpoint that is being measured here is not tumor response, but vascular damage. And vascular damage on this curve is clearly proportional, not just to the total dose that is delivered, but to the dose per fraction. So the top curve, where you see the greatest vascular damage or vascular volume loss, is 20 gray times 1. You get a dramatic reduction in the vascular volume. So this endothelial effect is a very big component of high dose per fraction. In fact, this was described by several people who are in the room here, and in fact, it was first described as SRS lesioning. We knew that if we took a large dose of stereotactic radiosurgery and placed it in the brain in different locations and different structures, and these are a whole host of different experiments that have been published, this is just a partial listing, we find that we can actually create lesioning at very, very high doses. But if you look at the doses here, they're very high. 400 gray, 200 gray by Lexell and Larson initially in goats and rabbits using proton radiation. We look at, for example, goat brain, 200 gray. If we look at the baboon model that Lunsford and Konziolka worked on, 150 gray, these are all very, very large doses that result in lesioning, vascular collapse, necrosis. The effect is very precise. If we just look at a series of patients treated with trigeminal neuralgia, this is a paper that was published in the Red Journal, we start seeing this enhancing component in the trigeminal nerve precisely where the radiosurgery target was placed. And this is not uncommon. In this particular paper, 65 of 78 patients who received 90 gray in a single fraction developed enhancement of the trigeminal nerve within months of irradiation. Highly focal, highly localized, just showing the focal localized ability of radiation to produce vascular damage, which allows contrast to leak through and create these contrast-enhancing lesions. Tony, sitting in the room here, probably recognizes this paper. Tony, this was your original work on lesioning in a monkey with very tiny targets, looking at the monkey basal ganglia and trying to see if, in an attempt to treat Parkinson's, I believe that's what you were looking at, Tony, whether you could actually produce effective lesions. And as you can see in the images at the bottom, it is in fact very possible with 150 gray to the subthalamic nuclei and substantia nigra to produce lesioning that results in tiny targets showing enhancement and destruction of tissue. So this leads us to the concept of radiomodulation. Radiomodulation is not just vascular damage, but actually functional alteration, a concept I actually ascribe to Dr. Raji, who's sitting here with us. He first described this, saying that high-dose radiotherapy selectively modulates epileptogenic signals without affecting other neurologic functions. And this is hypothesized to extend to treatment of conditions that are governed by neural nets, where SRS modulation at the nodal level can alter function, can alter the disease state, for example, even Parkinson's. It could be advantageous for disease modulation because it's very targeted, it's non-invasive, and can be repeated if necessary. There are several animal studies. This is a good reference paper. Again, we know who wrote this paper. We have everybody who did the work in this field right here in the room here. And this is a great paper to pull out. And you can see that there are a whole host of different results in terms of radiomodulation, from effects on voltage channels, sodium-sensitive voltage channels, synaptic transmission, epileptogenic firing, reduction in GABA activity, as well as action potential changes that occur from large dose radiation to different targets in different animal model systems. In the clinic, this is best illustrated by work that Dr. Raji and his colleagues have actually done in terms of modulating epileptogenic foci. Essential tremor, for example, is one of the most common disorders, and a dose of 130 gray SRS aimed at the ventro-intermediate nucleus in the thalamus results in significant resolution of this clinically resistant condition, lesioning resulting in tiny lesioning, as you can see in this imaging, but great clinical results. This is not restricted to the brain. There is tremendous interest in cardiac radiomodulation. The ENCORE ventricular tachycardia cardiac ablation trial was published in the New England, in Circulation by Robinson and colleagues from WashU in 2019. They reported 18 patients who received 25 gray in a single fraction to an arrhythmogenic target within the heart. And 17 out of the 18, 94% of patients had a favorable clinical outcome. These were end-stage patients typically sent to hospice to die, and they had a dramatic improvement. There is a significant body of experience with this technique, most of it off of clinical trials, but new clinical trials are currently being launched. We know that radiomodulation is dose dependent. Dr. Ye and his colleagues have demonstrated this in an animal model system where they looked at a variety of doses ranging from 0 to 120 gray in miniature pigs, who were then followed with MRI and PET imaging. Only 120 gray produced the lesioning, the vascular lesioning effect that I showed you earlier. But lower doses in the range of 10 to 40 gray all produced significant PET-based activity changes seen as early as 3 months. So we may need 120 gray plus to cause lesioning, but lower doses will produce a radiomodulating effect. Is this all part and parcel of chemical change, synaptic change, electrical activity change, or could there be an inflammatory component or something else going on? We know that there are immune stimulatory effects of high-dose radiation as well, and these are now being studied in the clinic in significant activity. Here's an example of a fractionation schema mouse model that was published by Devan and colleagues, where they showed that a schedule of 8 gray times 3 or 6 gray times 5 in a mouse model with 2 tumors implanted in each flank, with the other tumor not being treated, would result in the other tumor, the untreated tumor, disappearing after an 8 gray times 3 or a 6 gray times 5 fractionation schedule, but not with a single fraction radiation schedule of 20 gray times 1. So immune modulation could very well be a component of this as well. I'm coming up to the end of my presentation here, so I'm going to summarize with what I think are the takeaway messages for hypofractionation and radiomodulation. It's important to remember that hypofractionation is actually inherently dangerous in the clinic. It's inherently dangerous because normal tissues, which have low alpha-beta ratios, are highly sensitive to the high dose per fraction. So if placed in the wrong location, this is a very dangerous technique. So precision is an absolute vital key to radiomodulation, neuromodulation, radiosurgery. It is obviously advantageous for tumor control because we get away from acceleration, we get away from repopulation. We could be inducing immune enhancement. We could be inducing vascular effects that result in vascular collapse. And obviously, the radiomodulation component, which is the non-DNA damage, is something we're just beginning to learn. We know in the clinic, for example, in trigeminal neuralgia, we heard about patients getting off the table after radiosurgery and telling you that their pain is gone. All of us have seen these cases. We don't know how to explain this. Seizures, we've got a body of data that shows significant improvement. And arrhythmias, we now have a body of evidence for this as well. So I think radiomodulation, we're just scratching the surface. There's probably a long ways to go. And I'm really excited to hear the rest of the talks. Thank you.